provided a new acoustic window to the heart and mediastinum. Superior quality images of most cardiovascular structures can be obtained readily with an ultrasound probe in the esophagus. Transesophageal echocardiography has revolutionized cardiac anesthesia and has also become increasingly popular in the management of patients in the intensive care unit and during certain non-cardiac surgical procedures as well. The transesophageal application of ultrasonography to assess the cardiac function was first reported by Seid and Gosling in 1971. The early transesophageal probes did not attract clinicians because of the problems associated with the swallowing of the probe in conscious patients and also due to logistical difficulties of introducing rigid endoscopes. Is physics of ultrasound. In transesophageal echocardiography, the heart and great vessels are insonated with ultrasound from probe inside the esophagus, which is sound above the human audible range, which is above 20,000 Hz. Frequency within the range of human hearing, which is 20 to 20,000 Hz, are referred to as audio frequencies, while those above this range are referred to as ultrasonic frequencies. Ultrasonic frequencies are characterized by their wavelength, frequency, and velocity. Wavelength is the distance between the two nearest point of equal pressure densities in an ultrasound beam, and velocity is the speed at which the waves which propagate through a medium, and the number of cycles per second is called frequency of the wave. They are related by the equation, which is velocity is equal to frequency into wavelength. Ultrasonic transducers. A transducer is a device that converts energy from one form into another. Ultrasonic transducers use piezoelectric crystals to emit and receive high frequency sound waves. These transducers convert electrical energy from the ultrasound instrument into acoustic energy when transmitting, and they convert acoustic energy which is reflected from the tissues into electrical energy that is used by the instrument to form the image. And types of imaging techniques, there are numerous types which are M mode, two-dimensional echo, Doppler ultrasound, pulsed wave Doppler, continuous wave Doppler, and color flow Doppler. Equipment. Transthoracic echocardiographic views are particularly difficult to obtain in patients with obesity, emphysema, or abnormal chest wall anatomy. This is because bone, fat, and air-containing lung interfere with the ultrasonic preparations. Transesophageal echocardiographic transducers were developed to avoid these problems. They are mounted on modified probe similar to those used for gastrointestinal endoscopy. Sound waves which are emitted from esophageal transducer only have to pass through the esophageal wall and pericardium to reach the heart, improving image quality and increasing the number of echocardiographic windows. Other advantages of transesophageal echocardiography includes the stability of the transducer position and the possibility of obtaining continuous recording of cardiac activity for extended period of time during surgery. There are two types of probe available. The adult probe has a shaft length of 100 cm and a diameter of 12 mm, and a pediatric probe which approximately measures 7 mm in diameter. Movements of the probe. The transesophageal echocardiographic probe produces a 90-degree imaging sector which can be directed by a variety of maneuvers. The shaft of the probe may be advanced into or withdraw from the esophagus and turned to the right or clockwise or to the left or anti-clockwise. The tip of the probe may be antifluxed or anteriorly or retrofluxed posteriorly by rotating the large control wheel on the handle of the probe. Rotating the small control wheel which fluxes the tip of the probe to the right or the left, which is lateral flexion. The facility may not be available in the pediatric probe because of size limitation. All modern esophageal echocardiographic probes are multiplane as compared to older biplane probes, and the scanning plane can be rotated from 0 degree to 180 degree. At 0 degree, the sector scan lies in the transverse image plane, and at 90 degree, the sector scan lies in the longitudinal or vertical plane. Preparation for transesophageal echocardiographic examination. Anesthesiologists may need to insert the probe in awake or anesthetized patients. In both scenarios, the probe needs to be well lubricated. One need to be very careful in patients with a history of dysphagia, hematemesis, and cervical spine disease. An awake patient must be fasting for at least 4 to 6 hours before the procedure. Blood pressure and heart rate should be measured, and dentures and oral prosthesis should be removed, and airway, oxygen delivery system, bite guard, suction, standard crash cart should be made readily available, and intravenous access is generally established before the examination. Pre-medication. Awake patients are usually pre-medicated with topical anesthesia to diminish gag reflex and intravenous sedation to decrease anxiety and discomfort, and drying agents like glycopyrrolate to decrease salivary and gastrointestinal secretion to avoid the risk of aspiration. And for selected high-risk patients, antibiotics should be considered to prevent infective endocarditis. Technique of introduction. The pharynx is anesthetized with the local topical anesthetic spray. The patient is placed in the left lateral position and the neck slightly flexed to allow better oropharyngeal entry. Introduction of the probe can also be performed with the patient in the supine position and if necessary in the upright sitting position. A bite guard is essential to allow manipulation and protection of the probe. And distal portion of the transducer is coated with lubricating jelly. The echographer should passes the probe tip through the bite guard and over the tongue, maintaining it in the midline. The tip is advanced until resistance is encountered, and then the patient is asked to swallow with a gentle forward pressure. The transducer is advanced into position behind the card. When the procedure is over, the precaution that should be taken by the patient, including not to drink any hot liquid until oropharyngeal anesthesia has and not to eat until
Hello.
echocardiographic probe. The TE probe should be inspected for defects with the transducer tip in the neutral position and all flexed directions. These defects cause trauma or expose the patient to infective, caustic or electrical complications. After each procedure, the shaft of the probe and the bite guard should be cleaned and disinfected. They should be washed with enzymatic solution to remove saliva and secretions. Standard views and systematic examination. Images are collected at 4 depth. The depth of placement of transesophageal echocardiographic probe for adult patients are 4 upper esophageal, which is 20 to 30 centimeter, mid esophageal, which is 30 to 40 centimeter, transgastric, which is 40 to 45 centimeter, and deep transgastric, which is 45 to 50 centimeter. The American Society of Echocardiography and the Society of Cardiovascular Anesthesiologists had published the guideline for comprehensive intraoperative multiplane examination. They recommended 20 standard images. The great majority of images are obtained at mid-esophageal and transgastric levels. The goal is not to get all 20 views in all patients. The goal is to elucidate the structure and function of the heart and great vessels. We'll see about the views. First one is mid-esophageal views. It will divide into two groups. One is mid-esophageal aortic views and another one is mid-esophageal ventricular views. In mid-esophageal aortic views, which images the aortic valve and proximal ascending aorta. Totally 6 views obtained in this level. They are mid-esophageal aortic valve short axis, mid-esophageal aortic valve long axis, mid-esophageal right ventricle inflow-outflow view, mid-esophageal bicaval view, mid-esophageal ascending aorta short axis view, and mid-esophageal ascending aorta long axis view. The aortic root, aortic valve cusps, and interatrial septum, right ventricle, tricuspid valve, and the vena cava are assessed with these views. And we'll see about the mid-esophageal ventricular views. These views are important in the assessment of mitral valve, left ventricle, interventricular septum, and both the atrium. In transgastric view, totally there are 5 views: transgastric mid-short axis view, transgastric two-chamber view, transgastric basal short axis view, transgastric long axis view, and transgastric right ventricle inflow view. Obtained at this level are useful in the assessment of mitral valve, left and right ventricles. In particular, the transgastric mid-short axis view is very commonly used by the anesthesiologist in the assessment of left ventricle and its ejection fraction and volume status. Transesophageal echocardiography can image both aortic arch and descending aorta with 4 standard views using upper esophageal aortic arch short axis view and long axis view, and descending aortic short axis view and long axis view. Indications. There are numerous indications which are evaluation of acute, persistent, life-threatening hemodynamic instability in operating room or intensive care unit, Intraoperative use in valve repair, intraoperative use in congenital heart surgery requiring cardiopulmonary bypass, intraoperative use during repair of hypertrophic obstructive cardiomyopathy, intraoperative use for endocarditis, and intraoperative assessment of valve replacement and assessment of repair of cardiac aneurysm, and intraoperative detection of foreign bodies and detection of air emboli during cardiac or neurosurgical procedures, and during intracardiac thrombectomy or pulmonary embolectomy. And further indications are intraoperative use during cardiomyopathy, intraoperative monitoring of emboli during orthopedic procedures, and intraoperative assessment of repair of thoracic aortic injuries and use for uncomplicated pericarditis. There are certain emerging indications which are assessment of ventricle function in high risk patients undergoing coronary artery surgery and patients with coronary artery disease or ventricular dysfunction undergoing non-cardiac surgery, and during displacement of left ventricular assisted devices, and during deployment of intravascular devices such as endoluminal stenting of thoracic aortic aneurysm, and during position of cannula and as a substitute for the pulmonary artery catheter. Complications. Complications are divided into two types: probe related complications and procedure related complications. Probe related complications includes thermal pressure injuries, compression of the structures which is adjacent to the esophagus, or direct mechanical injuries to the esophagus or stomach. Procedure related complications such as circulatory complications which results in hypertension, hypotension and arrhythmia, whereas pulmonary complications results in laryngospasm, bronchospasm and hypoxia. There are certain absolute contraindications to transesophageal echocardiographic procedure, which includes perforated viscous esophageal stricture, diverticula, varices, scleroderma, and a recent upper gastrointestinal surgery and active upper GI gastrointestinal bleeding. And relative contraindications includes atlantoaxial disease, prior irradiation to the chest, and hiatal hernia. Sir, that's all, sir.
Excellent. Very good. It is a very detailed and very nicely written answer.
Yes,
this is informative for a classroom lecture. Very, very nicely prepared for a classroom lecture. But from examination point of view, if it is asked as a short note question, you won't have time to write all the points that you have prepared now. So you may have to cut out the physics behind the, because there is a short note question on physics of ultrasound itself. Sometimes it is asked as a separate short notes. So for the sake of class information for all the other PGs, it is a very nicely prepared answer. From examination point of view, you may have to trim it to the level that you can finish it within about 10 to 15 minutes. It is asked as a short note question. So there you can curtail the physics part of it and mention, reduce the detailed information on the various views also. You can just mention about the upper esophageal, mid esophageal, transgastric and deep gastric levels where the images are made.
Okay.
And one point we can add from practical point of view is the YT is not commonly practiced. If you are claiming so much of advantage of transesophageal echocardiography over transthoracic echocardiography, why it has not become a routine monitoring with just like your pulse oximetry or ETCO2 or your NIBP? YT has not become a routine monitoring for all cases.
It's an invasive procedure.
It is a semi-invasive. It's not a totally invasive. It is a semi-invasive procedure, number one. Okay, good. Second, any other point?
Difficult learning curve.
It is a learning curve is quite steep. You have to keep on doing it to identify and make out what is what. And the instrument is quite huge. It is not small. They have not yet brought out any portable TE machines. So they used to occupy a lot of space in the OT. Okay? So it was actually introduced mainly for cardiac procedures, where especially in the US it was introduced to identify the myocardium which is hypokinetic during revascularization. If it starts contracting again, they found that it was the correct method of identifying the re-establishment of vascularity to that area, especially in acute cases where it has the myocardium is either hibernated or stunned. If it is starting to contract again, it indicates a good revascularization and a successful revascularization. That is how it started its journey as one of the important tools for monitoring the cardiac function. But nowadays it is very useful in identifying the hypovolemic state of the patient, where the ventricles which are getting filled with the preload, if there is no adequate volume, then the ventricles start contracting so much that the papillary muscles come to such close proximity as it is, they are called kissing papillaries. Okay? If that is the sign that you elicit, it indicates a severe degree of hypovolemia, that the myocardium is trying to push all the volume that it receives into the left ventricle. And it is one of the important indication for adequate volume replacement to get the adequate preload. So that is a important use nowadays, even in trauma. So the indications for the use of TE, you can nowadays classify them into cardiac and non-cardiac indications. Of course, you mentioned all on a running note, but you can divide them into cardiac and non-cardiac. And in cardiac, you can say intra-op and ICU uses. If you classify and give headings like that, and when you write the theory paper, it will be more attractive and it will be easy for the examiner to understand that you have basic and good knowledge of about this, and give the marks accurately for you, so that the presentation also will look more elegant. I'll just can I show a presentation? So is it visible now?
Yes, sir.
Okay, right. So I'll just make a quick presentation of whatever he said. He has made a very detailed and nice preparation. Congratulations, Mani. So whatever points you have told will be there in this slide also, but I think it will be more in an orderly fashion. So the transesophageal echocardiography is a semi-invasive and real-time imaging modality. That is a very, very important thing. So you are seeing the heart as it is beating, and it's a real-time image. And how you do it in intubated patients? You mentioned that it can be used both in conscious and under a patient under anesthesia. So mostly we now use it in patients who are under anesthesia. For conscious patient, majority of them will go only for transthoracic. We don't do TEE that commonly in a conscious patient unless he is in the ICU sedation or something like that. But in operative conditions, we use it under general anesthesia. The probe is introduced into the esophagus through laryngoscopy, as it is less traumatic, and it provides a detailed dynamic real-time information about the high quality of cardiac monitoring, because it is in close proximity to the heart. It is only 1 to 2 millimeter posterior to the heart. So there are no intervening structures which you mentioned, like obesity, fat, ribs, lungs, all the so such intervening things are not there. So this gives a very good image of all these structures that we want to see, and these things, artifacts are prevented, and it can provide images even when there is a surgery going on with thoracotomy. So even when the chest is open, he is functional. So that is the biggest advantage why it is used as an intraoperative imaging modality. Intraoperative TE is performed usually after induction of anesthesia. You don't put the probe first. You first induce anesthesia, you intubate the patient, and behind the endotracheal tube, you lubricate and slightly flex to match the shape and curvature of the endotracheal tube and pass it into the esophagus. It is laryngoscopically inserted first into the hypopharynx and then advanced into the esophagus with minimal force, keeping a bite block in situ to avoid injury, which point you said. So even under anesthesia, it is better to use a bite block so that when the recovery time, if the patient clenches his teeth, there will be no damage occurring. And there are indications, absolute contraindications for it are esophagectomy, all those points he said, esophageal stricture, esophageal fistula, trauma, diverticula, or suture lines. And relative contraindications are hiatus hernia, esophagitis, coagulopathy, unilateral vocal cord paralysis, esophageal varices, post-radiation therapy, all these things are relative contraindications. And you can, as I said, divide them into use of in cardiac surgery. Most frequently nowadays used as a hemodynamic parameter to assess the cardiac output and left ventricular filling, that is the preload, and used for functional assessment of LV by identifying the global and regional left wall motion abnormalities as well as for the assessment of valvular dysfunctions. And it can be categorized by being safe for its minimal invasiveness and most relevant decision tool leading to fluid administration. As I said earlier, it can detect hypovolemia very accurately. Most common associated complication is odynophagia. That is, patient may have painful swallowing after the procedure. Even if you do it under anesthesia, patient may have sometimes severe painful swallowing. Other complications, especially if you do it in a conscious patient, dental injury, or you can under anesthesia, endotracheal malpositioning, upper GI bleeding, and esophageal perforation, all these things can happen. Coming to non-cardiac surgery, hemodynamic stability and rapid changes in the volume is the most, especially in trauma with acute blood loss. This is the considered as a very good tool for assessing the volume status. And during episodes of hypotension, this can be organ perfusion is rapidly impaired, and intraoperative complications may appear, resulting in ischemia. So nowadays, this has become a very important tool in organ transplantation. So the pathophysiology of hypotension, regardless of the etiology, may be either a pump failure, hypovolemia, or reduced peripheral vascular resistance. So for discriminating this, you have to find out what is the defect and correct it accordingly. Peripheral vascular resistance is dependent on the cardiac output. A normal or increased cardiac output in patient with hypotension usually indicates a reduced peripheral vascular resistance. And the assessment of cardiac output and cardiac preload may play a central role in advanced intraoperative monitoring. And in sepsis, a situation characterized by an increased leak of fluid to extravascular space and early goal-directed hemodynamic stabilization, or in particular volume loading in early phases associated with improved outcome. So nowadays, sepsis is also one of the important indications for a TE monitoring. And the most assessed echocardiographic technique for volume status is the evaluation of inferior vena cava and its diameter as a static parameter of preload, as well as ventilation induced changes reflecting a dynamic parametric of volume status responsiveness. Equal to this is the papillary muscle, which I will tell you later. The clinical utility or detecting hypovolemia, especially approximation of mitral papillary muscles, gives an accurate indication of intravascular fluid volume status, which is a transgastric short axis mitral valve view, where you will see this. Approximation of both papillary muscles, the so-called kissing papillary sign, signifies severe hypovolemia, and LVEDA, left ventricular end-diastolic area of more than 20 square centimeters, suggests a volume overload. So you can detect both hypovolemia and hypervolemia. And an LVEDA of less than centimeters, which is also called LVDA index, is less than 5.5 to square centimeters by square meter, signifies hypovolemia. And this is the TE can diagnose right or left ventricular systolic dysfunction or failure, hypovolemia, or pericardial effusion with tamponade, valvular dysfunction, ruptured ventricular septum, all of which are known causes of hemodynamic instability. So these are the not only the volume status, but other structural abnormalities also can be detected. And it has got a definitive advantage over other cardiac monitors which are in use, like pulmonary artery catheter or Vigilio flow track, since the left ventricle can be visualized in real time for regional wall motion abnormalities. So that is the point over which it scores over the other monitors. He is as a rescue in hemodynamically unstable patients by determining the cause of refractory hypotension. It's becoming more increasingly used nowadays. And in management of neurosurgical patients, he is extremely valuable to detect venous air embolism in posterior fossa surgery. So that is the main reason for using TE in especially sitting posture, posterior cranial fossa surgeries. And it has got greater sensitivity than Doppler. Previously, we were thinking a precordial Doppler will detect all the air embolism, but it is much more sensitive than that, even because it can detect even the micro bubbles that the anesthesiologist is forewarned of a potential larger venous air embolism. And in one of the ASCIIs, I found that these micro bubbles detected by a TE is that image is kept as one of the ASCII questions. So it will be like a shower of small bubbles coming into the right atrium from the SVC. So that is the picture that you will have to remember. Users. And in organ transplants, the TE is nowadays used for lung and liver transplant surgeries, which entail massive blood loss, extensive resection, and hemodynamic changes, and hypovolemia occurring despite high CVP because of pneumoperitoneum or Trendelenburg position can also be detected, cannot be detected without a TE. And TE in trauma patients, of course, I mentioned it earlier, especially chest trauma, hemodynamic instability due to external compression of the heart by either a tension pneumothorax or pericardial effusion or aortic dissections can be detected by TEE and treated easily. And TT in liver surgery, during acute blood loss, LA dimensions change earlier than CVP. So that is the advantage. So the left atrial size will alter much more earlier than the CVP. So this helps in the detection of intrapulmonary shunt also in patients. End-stage liver disease patients have intrapulmonary shunt which can be detected by TE. Which of course they use what is called the agitated saline test, which is injected into a peripheral vein, and presence of microbubbles in the left heart chambers 4 to 6 beats after initial appearance of the contrast on the right side is an indicator of intracardiac shunt. So that is how you detect it. And in pulmonary embolism, it is very useful to detect it at the earliest stage. And whenever you put a stent in the for aneurysm correction, as you said, endovascular repairs, that is also very easily detected. The location and the expansion of the stent can be easily detected. And in oncosurgery, nowadays they use it more in oncosurgery patients, again because of the extensive dissection and blood loss. And intraoperative cardiac arrest during non-cardiac surgery, he is trusted to detect the stoppage of the heart before you lose the pulse and you lose the circulation. And patients with congenital heart disease undergoing cesarean section, that is also another indication now recently included. And in scoliosis repair, again, because of the large dissection and blood loss, as well as the chances of air embolism are high. So in scoliosis repair also CE is indicated. So we saw earlier about the indications in cardiac surgery, valve repair and coronary revascularization. These are all the non-cardiac surgery indications for the same. Now some of the views which you can have to just remember in case they are given as a nasty question, without this is the basic thing every one of us should know. When the ultrasound beam is passed like vertically like this is called the long axis plane. So this is the plane, and if it is cutting across the structure, it is called the short axis. And when it goes in the posterior, encompassing all the areas of the heart or the structure, it is called the four chamber plane. So these are the three basic views: long axis, short axis, and fourth chamber. And in the long axis, if you see, you will see both the atria, both the ventricles. And in the short axis, it will be more to one at the valvular area. It will be as like a cross section. And in the fourth chamber again, it will be a inverted image of what you see in the long axis. So it will be more to find out the emptying of the atria into the ventricle. So this is the basis that we should know, so that we can identify. Sometimes they give the images in the husky and try to identify. So if you see a lengthy picture with all the aorta and other things, this is the long axis. You see the valves in the cut section with two openings, it is the short axis. And if you see all the four chambers, it is the four chamber view. And these are the four standard positions for the transducer, which is called the upper esophageal, mid esophageal, transgastric, and deep transgastric. These are all the various levels or the length of introduction of the probe. So this was mentioned by Mani. So you can just see those numbers. So deep gastric means you have gone into the stomach itself, maximum length of 42 centimeters. Whereas the transgastric, it is 38 to 42. Mid esophageal is about 29 to 33. Upper esophageal 27 to 28. You can imagine what are all the things that you will be able to see. See, if the probe is in this position of the upper esophagus, it will be looking more like a long axis view. And if it is the mid esophageal, you can get a long axis as well as a short axis. And transgastric, you can see these are all the structures that you would like to know. And deep gastric, it will be from visualizing the heart from the apex towards the upper end. So it will be like a four planes view. So this picture will tell you what are the structures you can visualize. And so this is what about the probe, what are all the movements the probe can have. There are two things with the probe. One is the entire probe movement. The other is the transducer movement. So the tip has got the transducer. So the transducer alone can move, or the entire probe can move. And in the probe, there are four movements. One is it can be advanced or withdrawn. It can be turned right or left. It can flex right or left. It can antiflex and retroflex. And it can rotate into angles 0 to 180 or 180 to 0. So there are 6 movements totally for the probe. And for the transducer plane, there are transverse plane, longitudinal, and omniplane. So transverse means no movement 0 degree, longitudinal 90 degree, and omniplane 0 to 180 degrees. And with this, you will get this sort of 3 images: pie-shaped sector, display right or left, and near field or closest to probe. So this is how all the images will be seen. So this is the 6 movements of the probe: 1, 2, 3, 4, 5, 6. And this is how the transducer can move in various planes to give the images. So this is the probe which is seen as it is in the live position. So it has got the control knob here to rotate and flex or anti-flex all these things. And this is the entire probe, and the transducer is there at the tip of it. And these are all the various movements it can undergo. And so this picture will tell you about the plane, how it is going to orient with the hand. So you can use this to imagine whether it is being seen in the image is created by multiple CAR lines in the back and forth from the patient's left green line. So this is the creation of the hand as I described for text for imaging planes at 0 degree. So if it is at 0 degree, this will be the hand. When it is rotated to 90 degrees from 0, this is how the whole thing changes. So this is how the image will be changing when you do that at the various levels. Just to have a imaginary idea instead of just reading, you can see these pictures later on to see how it is being done. And in the mid-esophageal view, the transducer is here in the middle of the esophagus, and it is going through. You can see the rays are going through both the atria and the ventricle. So it is usually used for 5-chamber view. It's advanced slowly to a depth of 30 to 35. And you can see the mitral valve very clearly in the scene, and you can also see the LA, RA, intraatrial septum, LV, right ventricle, interventricular septum, mitral valve, all the cusps, and the tricuspid valve. So all these structures can be seen by the mid-esophageal 4-chamber view, and this is how the structure will look like. So you can see the LA here, RA here, the tricuspid, mitral valve, LV, RV, the lateral wall, even the coronary sinus is seen, is opening. So all these structures are made out in that. So if this picture comes in the examination, you can say it's a mid-esophageal 4-chamber view. And if they have named it already as LA, RA, RV, LV, then it is much more easier to identify, and you can say it is a mid-esophageal 4-chamber view. And these are all the defects that you can diagnose: chamber enlargement, LV systolic function, mitral valve pathology, or tricuspid valve pathology, if there is a atrial septal defect or pericardial effusion. All these pathologies can be detected by that. Then there is another view which is commonly used, is called the mitral commissural view, where the from the 4th chamber you just rotate the transducer to an angle of 50 to 70 degrees. It will generate the mitral commissure, and from this neutral probe orientation, turning the probe leftward, you will see the posterior mitral leaflet. If you turn the probe clockwise or right, you can see the anterior mitral leaflet, and it is mainly for the LA, mass or thrombus, LV systolic function, and any mitral valve pathology. Especially if you have a mitral stenosis, you can assess how the mitral leaflets are there, whether they are pliable or whether calcified, all those things. And so this is the image that you will get. So this is the LA, this is the LV, this is the mitral valve that you can see the 2 leaflets are there. Then there is a mid-esophageal 2-chamber view. Earlier we saw the 4-chamber view. There is a 2-chamber view, which is again for LA, left atrial appendage thrombus, or LV systolic function, or LV apex pathology, or mitral valve pathology, where you can detect that. And this is how the whole thing looks like. And this is the long axis view, again for mainly left ventricular functions. And this is how the image will look like. So how you can do that long axis? You first go for the 5-chamber view. When you advance it a little bit, you will get to the 4th chamber. Then you go to the commissure view. Then you get the 2-chamber view. Then you get the long axis. So by slowly advancing the probe, the first thing you start with is the 5-chamber. Then you will get a 4th chamber. Then you go for the mitral commissure. Then you get the 2-chamber view. Then you go for the long axis view. Then, as I said, bicaval view is another important view which we have to use for assessing the SV IVC flow, inflow how it is, and venous catheters. If you are introduced any catheter, the central line catheter sometimes may be entering these areas, or a PA catheter may be there, or pacemaker wires may be there, or venous cannula position, SVC, IVC, all these things can be detected. So from that point of view, the bicaval view is very, very important, and that is how it looks in the image. And this is the transgastric two-chamber view. Again, you can see the valves, and this is the again mid-esophageal short axis and the right chamber views. So just for familiarizing the image, how it is there. So you can see RALA, RVLV, left ventricular outflow tract, aorta, everything is seen. If all these things are seen, then it is a 5-chamber view. And it is the short axis atrioventricular view. And this is the inflow outflow view, which is also important for finding out any right ventricular pathology like pulmonary valve stenosis in your tetralogy of Fallot and the tricuspid pathology. All these things can be made out in this right ventricular inflow outflow tract view. So these are some of the common things I thought I will share with you so that can be shared. Okay. Right. So that